Good morning, Dr. Pia. I'm super excited to have you on. I've been wanting to have you on as a guest for some time. And when Joanne ran into you at the conference you guys were just at together, I'm like, okay, again, universe is aligning. We have to make this happen. So good morning. Thank you for taking your time to come and chat with me. And yeah, I'm just super excited to, for you to share everything about your practice. I love your approach to the collaborative care model you have. So welcome.
Thank you. Thank you so much for having me. Similarly, I've been wanting to be on the podcast, so I'm so glad this worked out this morning.
Awesome. All right. Well, let's first start with I want to know everyone to know your journey, how you got to, from pediatric dentistry, traditional to airway dentistry. Just share your story a little bit with us.
Yeah, so my journey to pediatric dentistry was not traditional either. When I finished dental school, I did a general practice residency because I live in New York. I lived in New York, and that was required. And even then, during dental school, my professors would say, "Oh, you should really specialize in pedo," but I was like, "I'm done with school. I just want to start working." So I did, and I practiced as a GP for about 6 years. In that process, I moved to Texas, where I continued to practice as a general practitioner, always still like gravitating towards children. And my decision to go back to residency was really made once I had my older daughter, Syra, because I thought as a mom, if I was going to take her somewhere, I would want it to be to a board certified specialist. So it felt unfair for me to ask parents to allow me to treat their children as a generalist when there was an opportunity for me to further my education. So given that we already lived in Houston, I only applied to the program here. So it took me a couple of years to get in. And I knew going in, I had now worked for other people for 6 years. I knew I wanted to open my own practice on the way out from like a startup. So during my first year of residency, I started looking for spaces in the neighborhood that we lived in. And I actually found my first practice space November of my first year of pediatric residency, and it's 2 years. Luckily, my landlord was super gracious and was like, "It's totally fine. We need this as a flex space anyway for a little bit." So I basically started building out the practice during my residency. And during that time, I had my second child as well, just like wanted to get it all out of the way so I could focus on the practice in the end. As a parent, that never happened. So anyway, when I was designing the practice, tethered old tissue, airway was nowhere on my radar. I just thought, I'm going to do bread and butter pediatric dentistry. What I knew is that I wanted it to feel like home because I wanted that experience to be what I would have wanted it for my own children. And so from the get-go, it was a very personal practice. Like my logo is done by my middle school best friend, and she did all the artwork in the office. And so everything had a very personal touch, but again, didn't know that it was going to take this sort of functional route. During residency, I learned about tonsils, adenoids, and kids that, looked like they weren't sleeping well. Still wasn't in the realm of like oral development or tongue tie. But coincidentally, at that time, my older daughter started snoring, having crazy tantrums for no reason. And now I look back at our 0 to 1 year, and she did not breastfeed, which took a total toll on me as a mother. I was, depressed after having her because I wasn't meeting my goals that I had like so vividly set forth, being a first-time mom. And so at this point, what I knew was she was not sleeping well. It was not normal for a kid to be snoring and to have bags under her eyes. And so we went down the tonsil adenoid route and took out her tonsils and adenoids. And it made like a marginal difference, just like I see with my patients now. Like, okay, the snoring sound got better, but they're still not sleeping well and they're not functioning well. And that was exactly her. Like the tantrums, it was almost like she was possessed, like couldn't get through to her. Luckily, I, at the time, had decided, oh, I'm going to get a laser for my practice because no one else in my area had a laser. And let me explore this like tongue tie thing. And I was mainly focusing on infants, but I went to a course by Dr. Zaghi, and he started talking about kids with tongue ties and how it impacts their airway and sleep. And literally, it was like every single symptom that Syra had. And to the point, like I started crying during this course because I was just like, how did I not know about this? So this was 2017. Came back home, looked in her mouth, posterior tongue tie, lip tie. Um, and I had a water laser at the time. But, you know, at that point, there was some talk about myo, but not the way we talk about it now with tongue tone and tongue space and all that stuff. So I just like released her, you know, clinically, it looked great. But again, like the functional difference was minimal, right? So I thought, okay, I gotta figure this out. So that's when I just started educating myself, taking courses, and then it led to expansion work because once I figured out that she didn't have space for her tongue, I needed to figure out, well, who was going to expand this, you know, young child under 5? Nobody really. So that's when I got into the expansion space and you know, there are benefits to being a second child because my little one, we obviously caught everything from the get-go. But, you know, it's been a journey. Like initially, a lot of my quote unquote expansion work was done with things like a myo brace, but I have now sort of transitioned to more custom-made expanders, and I'm an ALF provider, and I've done orthotropics with Bill Hang, and I've taken Kevin Boyd's and Ben Miraglia's course. So I've just kind of done it, tried to get all the pieces. And through that journey, obviously recognizing the importance of a multidisciplinary team. So the second time around when Syra was about 7.5, I re-released her tongue tie, but that was after expansion, chiro, myo, nutritional changes. I mean, all the things. And obviously the results were totally different. So that's when I came up with the function first model, which is the model that I teach on. And the gist of it is basically that you can't do any of these treatments isolated. You can't just do the therapy. You can't just do the expansion. You can't just do the tongue tie release. You have to look at the whole body and the whole picture. And it's continues to be a journey. I mean, constantly learning through my practice and the mistakes that I make, but also learning through collaboration and other practitioners.
Can you talk a little bit about the multidisciplinary team you have, like right in your own office?
Yeah. So when we started the practice, it was just me and a laser. And as I recognized the importance of other practitioners, you know, I started connecting with people in my community. And, you know, when I teach my course, people are always a little overwhelmed by, well, how do I get all these people in my office right away? Well, it didn't start like that. You start by making relationships with good practitioners in your community. And then you find the ones that practice like you do, and you guys are on the same page. And that's what happened for everyone I have in house now. I worked with initially outside of my practice. So currently we have IBCLC. We have 2 SLPs, one that is feeding focused for the under 3s, one that is articulation and more speech focused, that she's also myo. And then we have a RDH that's a myofunctional therapist. We have a pediatric chiropractor. I would love to get a nutritionist in-house. It's been a struggle to find somebody, but all of these people, we had to first get to know each other before jumping to, well, let me be in your office. Because once they're in your office and they're in your office, you are representing each other. So you have to make sure you're on the same page. And the first person is not always a good fit. So we've had multiple people. And also some of them have been just so amazing that they all have outside private practices. And once their practice takes off, some of them don't have the capacity to be with me anymore. And I mean, it's a good and bad problem, but
Right.
what we really have tried to do is build each other up and learn from each other. And so I would say in our office, maybe about 20% of my patients see our in-house practitioners. And we have people that travel from all over Texas. So sometimes it's a convenience thing. Sometimes it's a financial thing. Sometimes it's a scheduling thing because they're not in my office all day, every day. But the reason we really put them in-house was also for convenience, for parents that didn't want to call one more place, make one more appointment. So if they want us to coordinate everything, we can just do it during that consultation, and it's a no-brainer. So I know as a parent, sometimes that's a barrier. It's the driving and the convenience and the calling and the making appointments. So really what I tried to do in the practice in general is look at it through a parent's lens, and try to break down barriers so that our patients can get the treatment that they need.
And what about like when you're referring a patient, like how, because a lot of parents, I feel like you recommend myofunctional therapy, they're like, oh, well, we see a speech therapist. And how do you like differentiate a speech therapist that isn't myofocused
Yeah.
between that and a myofunctional therapist?
So it's always a tricky conversation, particularly if the speech language pathologist has referred them to me. Like they recognize there's a tie. And, so I don't want to take business away from them or break that relationship. But what I try to do is just educate parents and say, this is a subspecialty. And in preparation and recovery for the tongue tie release, we need a certain type of therapy. So for this, 2 months before, 2 months after, I'm going to have you switch to another therapist. And then once we're recovered and strengthened, then you can switch back to your therapist. Right. And I make it a point to say, it's not that you have a bad therapist, they just don't have this skill set. And we want the best outcomes. Similarly, with a pediatrician, with the infants, when parents come in and they say, why didn't my pediatrician pick up on this? They're just not educated in it. They're not bad pediatricians. They can probably do everything else in the pediatric scope just fine. So that's what I say. And I, encourage them, if this is a good speech fit for you, once we're done with the myo, go back to them. Right. Inevitably, once they're with a myo speech combo, which a lot of our therapists that we work with they do tend to stick with them because there is a difference in skill level, even on the speech side. There's been more education. And I feel like those things, sure, you can separate them, but they also go really well together. Absolutely. So we can work on speech while we're working on myo. So it's a tricky situation, but at the end of the day, I want the best outcomes for my patients. So, if that means telling them they need to go somewhere else, that's what it means. And I'm also the type of practitioner where most people have my cell phone number, most speech language pathologists, and I will reach out and say, hey, listen, like this is the situation. Thank you for your referral. Also provide resources and say, if you ever are interested in knowing more about myo or knowing more about tongue ties, like come visit the office.
Yeah, absolutely. I love that. Now, what about, I'm sure you get this question all the time, and I know it's not an easy question to answer, but I guess maybe like we can answer it in like a perfect scenario.
Sure.
When we talk about release before expansion, after expansion, what are your thoughts on that?
If I have the like gold standard, in my opinion, it's make space first and then release the tongue. The exception to that is when they're much younger. So if you look at, and I don't have the graph with me, but the graph of the growth of the maxilla, the growth really peaks at age 4. So any kid close to 4, 3.5, 4, and beyond, if they are narrow, just releasing their tongue is not going to catch them up. So if they are, especially if they are reporting sleep concerns, then I'm going to push for that expansion first, because we know the jaw structure impacts the sleep much more than just the tongue positioning. Sure, we can get some opening of the airway when that posterior tongue is elevated to the roof of the mouth. However, if they're significantly narrow, it's not going to be enough. So most of the time, like when kids call or parents call our office for a consultation, some of them will call saying, my child has a tongue tie. I would like a tongue tie consultation. Well, then we go through a whole list of questions. And if there are any sleep issues, snoring, anything like that, well, then that's being converted to an airway consult. And yes, that involves screening for a tie, but it also involves taking a CT, looking at the airway, assessing tonsils and adenoids, looking at the structure from, all three dimensions. And so many times, those are the conversations we are going to expand, then we're going to do myo and body work. And a lot of times we're doing body work during expansion, if I can get parents to do that. Then we're doing release, and then we're doing the myo and the body work some more. So obviously that conversation can be difficult if a parent comes in and their number one concern is speech. And I'm saying, well, actually, we're now going to be delaying this tongue tie release for about a year because I'm going to expand first and do some retention and then myo, and then we're going to release. So, but a lot of times when I explain to them why, and explain to them that actually some speech sounds are made by the tongue contacting the palate. So if the palate is in the wrong spot, we're still not going to get the speech results you want without expansion. So a lot of this is education. And I spend most of my day talking, not really doing a lot of dentistry. It's a lot of talking. And, you find ways to translate that, not just with my words, but handouts and videos. And because for many of these parents, this is the first time they're hearing these things. I would say parents are getting much more knowledgeable and it's out there. So a lot of them will come in kind of having an idea. But then it's also talking about, well, what type of expander is appropriate for my child? The ALF or ALF, huge buzzword. I use it very selectively. So, then I have to explain, why aren't we using this? Or why am I recommending this? And, again, my treatment is not always for everyone. My goal is to educate them about what the options are out there. And it's their child. I want them to want to do this type of treatment and see the value that it can have for not just the child, but the entire family, because a child that is sleeping well totally changes a family dynamic versus a child that is not sleeping well.
Absolutely. What types of patients would you say you lean more towards an ALF for?
Mainly like kids on the spectrum or my sensory kids, because they tend to handle the slower movement better. But I really think that in order for it to actually work well and move bone, not just tip teeth, you have to be doing the body work. You have to be doing the myofunctional therapy or oral motor therapy in order for it to really make a difference. And sometimes that's the barrier, because parents hear this buzzword and they just think, I can put this light wire appliance in and it's just going to work magic. There's a lot of work that goes into it actually being effective. And when I tell them the other things that they have to keep up with, a lot of times they're not ready for that. The alternative that I've been doing, if a kid is really sensitive and maybe has some oral aversion, is that's when I tend to use a myo brace as a training desensitization tool. I don't expect it to give me significant expansion, especially when they're older than like 4-ish. But I give them out for free I'm just like, here, go use this for 3 months. Go use this for 3 months. Let your child explore it. Don't force them to wear it. We're not on a schedule. We don't have to wear it all night. Just have them practice with it. And usually they're coupled with a therapist while working through this.
Right.
Because it's always more effective when we do a therapy with our, myo brace or myo munchie. And that's what I use it as. And it has worked wonderfully. Like usually those kids come back 3 months later and they will let you in their mouth. They're okay with we don't do impressions with the scanning. So that's what it just takes time and giving them some tools. And also what I like about the myo brace is it's helping train the tongue to elevate. And then that tongue is desensitizing that palate and the gag reflex and all of those things. Even if they're restricted, it is going to give us some more movement than what we've had. And then,
Right.
of course, chiro care, like regulating that nervous system as much
Mhm.
as we can.
What about those families that come in that, as you said, ELF, ALF, whatever you want to call it, being the buzzword, that are like convinced that they need to do ELF
Yep.
because it's, easier on the body, and they're nervous that if they do, like a fixed expander, that it's just way too invasive. Like, I
Mhm.
guess if you want to talk a little bit about like your turn cycle, and just kind of
Yeah.
explain that to parents.
Yeah. So this is how I run my practice in general.
Mhm.
Um, I will give them pros and cons, ALF
Mhm.
versus a fixed versus a removable. And this is why I would recommend whatever for your child. But ultimately, it's your decision. If you've now heard the pros and cons of everything and you still want me to do this ALF or this fixed or whatever, let's do it.
Right.
Like, we now have full disclosure and
Yep.
you've made a decision. I'm fine with that. I know putting in the ALF, I'm not doing harm. So I'm okay with it.
Right.
One thing that I do explain to them, though, is that changes may be slower because bony movement is going to be slower. We never do rapid expansion anyway. That's just not on the table. Kids that are under 6, we do use a screw like key
Mhm.
expander, that has the sort of rapid misnomer. But we are activating or turning it 2 times a week.
Mhm.
So that is half a millimeter of a screw turn. That doesn't mean the body's even moving half a millimeter.
Right.
So, what I tell parents is I have never had to take out a fixed expander because a kid is in pain, because we're
Mhm.
just not activating fast enough for that to cause discomfort. And we don't want to activate that fast. For
Mhm.
kids over 6, we do it 3 times a week.
Okay.
Still, like, the battle there is if they're going to compare it to the regular orthodontist, they're going to want to know, why am I in this so much longer? Well, it's
Right.
because we're not activating that quickly. But also, when we're moving bone slowly, the new bone will refill in while we're moving. We don't
Mhm.
create this massive gap and then bone has to fill in because we have a much higher chance of relapse then.
Mhm.
So we tend to see really great results. And even with our slow expansion, we leave the expander in 6 months post turning for retention.
Mhm.
And then we take it out, and then we don't put a retainer in because these kids still need to grow more.
Right.
And we're doing the myo and the tie releases. So that is going to be our natural retainer and growth guider.
Do you ever use a myofunctional guidance appliance for like that retention phase, or just the myo and natural growth?
Um, I like a myo brace.
Yeah.
Yeah. So I played with that for a little bit. And the one thing that I really didn't like about it
Mhm.
is I found that it did some maxillary retraction during that retention phase because it's an appliance where the maxilla and the mandible are attached.
Mhm.
So I didn't like that because I don't really want to retract anything almost ever.
Right.
What I will do sometimes is like a lingual holding arch
Okay.
as a longer term retainer that has some omega loops on it, so I can open the omega loops to continue some expansion. Also, the reality is when I'm expanding these kids, I'm giving them like a good buffer of millimeters beyond what's normal for their age.
Mhm.
Um, and so sometimes if we're struggling with myo and we're still mouth open breathing, I will say, yeah, let's put in this lingual retainer for an additional 6 months to a year, because
Mhm.
I've already grown you to a year or two from now anyway. So if we don't grow a lot, it's okay. I've already given you that buffer. But
Right.
that way, the lingual retainer is not across the palate. We can still do myo. We can still get the tongue up. It almost looks like an ALF.
Mhm. Mhm.
And essentially, I mean, I guess you could use an ALF as a retainer too.
Right.
So I tend to lean more towards a wired retainer rather
Mhm.
than a myofunctional, like a
Okay.
myo. But I love myo munchies. I use them all the time.
What about, because I'm sure you get this a lot too, families that come in whether it's tonsils or adenoids enlarged, like obstructing, I don't know, 85% plus obstruction, and families don't want to do surgery? Or are you more in the school of thought of regardless, let's try expansion first and see what happens and then intervene surgically? Like, where do you fall in that?
Yeah. So ideally, we avoid surgery just generally. Like, that's just
Mhm.
my take on that.
Mhm.
However, what I have found just through experience is if we are 85, 90% obstructing, um, kids really struggle with that expander. Like, things get so much worse and they freak out because, we're taking up now the little bit of space that they have left. We are now putting an appliance in there.
Right.
Um, and then what happens is they go even into more fight or flight mode. And even if I take out the expander and then we go do tonsil adenoids, well, now they're just terrified of that expander because
Right.
now they've essentially been choking on it.
Okay.
So when it is that obstructing, like that enlarged, I tell parents, like, unfortunately, I don't think there's a way around this.
Right.
This is a case where I just think like we have to go get these adenoids and tonsils taken care of. And then your child will really thrive with this expansion. We'll see the
Mhm.
results.
Mhm.
And a lot of them don't want to hear it, but also like initially, I think I was trying to be a hero and listen to their needs only. But then
Right.
in reality, I have to tell them like, okay, this is just not realistic.
Right.
And again, they may walk away and find someone else that is going to be willing to do it. But after seeing it a few times, it was just like, this is not worth it for your kid.
Right.
Yeah. And most of
Um,
the time, once I explain and they get them removed and come back, it's great.
right. And I feel like too, many parents like, they don't want them out because, well, A, they're part of our body, B,
Yeah.
their immune function. But like,
Yeah.
if you're not breathing well and you're not sleeping well, like your immune system's already crap.
Yes,
So, so
exactly.
they're not even able to serve the function that they're supposed to,
Yeah.
Um, and
But
then what?
if they're like borderline, like
Mhm.
50, 60%
Yeah.
and under, and the kid doesn't like look like they're in distress at
Yep.
baseline. Like, we
Yep.
do the popsicle, like tongue depressor um, test. Then, through like Audrey Yoon's study, like we know things can
Right.
shrink. We teach nasal hygiene to all of our patients, expansion or not, just generally at wellness visits. So I tell them, like, this might be a problem.
Mhm.
However, let's try expansion, let's try nasal hygiene, let's try some other things, and then let's reassess. Sometimes we're done with expansion and they still look inflamed, but the kid's totally asymptomatic. Well, I don't have a
Right.
problem with that.
Right. Right.
We're just going to watch that.
And where does the nutritional aspect come in? Like, are you often talking about like elimination diets, like for those patients, like gluten, dairy, things like that? What are your,
Yeah. And I that's one area where like I would love to grow more and learn more as a practitioner. But yeah, I do talk about just generally like processed food versus whole foods and just being cognizant of that. Like anytime you're offering your child something, if there's a whole version of it versus a process, like let's try to move towards those things. And
Mhm.
then, yes, I talk about gluten and dairy, more so dairy initially. Um, and some of these parents are already kind of on board with this. And some of them are just like, what are you talking about? So I try to tread lightly and see where they're at.
Yeah.
But I also bring it back to like my children and my family and tell them, like, my older daughter, when she eats dairy, you can like mucus and you can just tell, she also has really bad eczema. And so I don't dive as deep into the
Mhm.
nutrition as I would like to.
Mhm.
Um, but I at least like talk about some of it and tell them like this is something we should consider, especially if we're starting this process and symptoms continue to linger, then we need to start looking at other things.
Right.
Similarly, with like the chiro care,
Yeah.
that's always an interesting conversation. One of my practices is a mile from one of the biggest medical centers in the country.
Mhm.
And I have a ton of physician families. And when I tell them that they need to go see a chiropractor or it's a really good idea, it's a hard conversation to have.
They're
Um,
very just
but
resistant, but
yeah, yeah. And, you know, sometimes I'm recommending it for things like habit cessation, like thumb sucking. I never put in a crib or anything else. I'm like, your child's doing this for a specific reason to regulate their nervous system. So
Mhm.
let's help them regulate it by doing some cranial work,
Mhm.
and they'll be much more responsive to eliminating this habit. So again, it's about showing them, answering the why rather than just make it
Right.
blanket statements. And I think that, like, as a physician, dentist, whatever kind of doctor you are, I think a lot of times we make the mistake of just saying our recommendation with no reasoning. And
Mhm.
then, I mean, if I were a parent, I wouldn't do it either. Like, why? You
Right.
know? And that's where, when we talk about the nutrition stuff, when we
Mhm.
explain the why and how, like, gut microbiome affects things. And again, it's wonderful that now there are so many podcasts about it, and people are just hearing about it, that the conversation's a little bit easier.
I know we were talking about this a little bit earlier before we started recording. I was telling you I had my girls and they went through tether
Yeah.
tissue releases, and I appreciate everything, or look at it all much differently now as a parent. We also started down the route of baby-led weaning the last two
Mm.
weeks.
Uh-huh.
And, again, so different going through it as a parent. It is hard sometimes as a parent to separate what you know professionally and then just your
Yeah.
reaction as a parent, right? So yesterday we tried chicken, rotisserie chicken, and my daughter did exactly what she's supposed to do. And what did I do? I freaked out and I took the piece of chicken out of her mouth because I was nervous she was going to choke on it. And I
Right.
was so mad at myself. And I'm like, Brittany, what are you doing? Like, this is literally called baby-led weaning. You need to sit back and relax. Like, she's going to figure it out. But it's hard
Yes.
as,
Yes.
again, that parent brain, right? Like, your
Yeah.
first instinct is like, protect.
Yes. And I think, like, it's normal and it's natural, you know, for you to have that. And sometimes, like, I meet, and I've treated several myofunctional, like, where the mom or is a myofunctional therapist and very well educated in Airway. And sometimes we know too much,
Mhm.
where we don't just let, like, even when professionally, we just don't let the process happen.
Mhm.
Like, specifically one family, it was like, you know, the mom kept intervening. Well, let's switch to this. Let's switch. It's not working. I'm like, you have to let a process happen. And I know we're seeing red flags. Like, we know all the red flags, right?
Right. Right.
We don't have the luxury of ignorance is bliss, but
Mhm.
also we know that things don't change overnight,
Mhm.
you know? So with my children, it's the same way. Like, my older one has literally been through everything. And sometimes I'll still catch her, like, mouth breathing, and I'll freak out. And I'm like,
Mhm.
what? Why are you mouth breathing? And then I'm like, well, maybe she's a little congested today. That's okay, you know? But again, it's like the balance
Oh,
of
yeah.
just just letting them be, just letting them be kids and letting them do their process, and the constant, like, I can make it better. I can make it better. I can do this. Let
Yes.
me intervene here, you know?
Yes. Oh my gosh. I am so fighting that battle right now. And
Yeah.
just my personality. Like, I need to, and I think definitely motherhood's helping me kind of relax in a way, because I have a very type A tendency, and I don't want my children to be that way. It's a good thing, right? Type A people, yes, there's many pros, but the cons, I don't want them to have that. So I'm
Yeah.
trying to take a step back, but also obviously at the same time giving myself grace because there's two of them. So I'm quite
Yeah. Oh
often
my
very
gosh.
frazzled.
Yes. Yeah. I will also say, like, when I, you know, went through the release the second time with my older daughter, and we had to do all the things the myo in particular, like, I have so much more empathy for my families now, because keeping up with those appointments and those exercises was the hardest part of all of it.
Yeah.
And, you
Yes.
know, it's easy to be like, they'll just take you a couple of minutes. But when you're driving to ballet and cooking dinner and trying to work and
Right.
do all the
Yeah.
things, I mean, you forget about the
Right.
2 minutes of exercises, and it was a struggle. It was a struggle.
Yeah.
And so now when I talk to parents, I'm like, this is a commitment and it's not
Mhm.
easy. And I
Mhm.
get it. So like, this is not an emergency. Let's not rush into it and do it halfway. When
Yeah,
you're ready to make this commitment, we're going to do it the right way.
absolutely.
Um, and yeah, so, and I always tell them, I said, I think the biggest barrier for myself and for most families is committing to these appointments.
Mhm.
But I also know it's like not worth going through the procedure if you're not going to do the therapy before and after.
Yeah, and I always have that conversation too with families, and even like when I teach my course, like that you have to have that family has to be on board 100% because at the end of the
Yeah.
day, myofunctional therapy, it's 98, 99% patient compliance. And their
Yeah.
commitment to the program is going to reflect my work as a therapist,
Yeah.
unfortunately, right? I could be the best therapist in America, but if they're not doing their exercises, we're not going. So it's just you're wasting everybody's time, right?
Yeah.
And so I'm totally on board with that. And that's one of the things too I love. Like Dr. Boyd even talks about how even when it comes to his side of things with the structural component, like if the family's not on board 100%, both parents, like wait, because everybody
Yeah.
has to have the buy-in.
Yeah. Yeah, and
Um,
I think especially with when we're doing expansion, and I
mhm,
have to remind parents of this, like we are working with a human body.
right.
So we can turn an expander or we can put in an ALF. And yes, there's some predictability in what we're doing. That's why we do it.
Mhm,
But we also have to see how the child responds.
mhm,
Like some kids are on this twice a week turning and they come in and they've totally exploded. Like it's
right.
insane. And others, they've barely moved because their body has so much more resistance.
Mhm,
And sometimes we don't know that until we start. And
right.
so if everyone's not on board, then you run into the issue of why isn't this working? You told me this would work, instead of understanding the like concept behind it that we're
Right.
working with your child and we're going to have to see this is like multifactorial, you know?
Yeah, absolutely. Oh my gosh. What about do you work with an allergist? Like what's your because I just feel like there's so many kids with
Yeah.
unmanaged allergies and
Yeah.
it's not the tonsils and adenoids, right? Sometimes it is these crazy allergies. So
Yeah. And Houston in particular has really poor air quality. So a lot of our kiddos have tons of allergies.
Mhm.
So I work with one allergist is literally in the building next door to me.
Oh, that's great.
Um, and then so I really only have a couple. One does like the more traditional allergy shot type thing.
Mhm.
And then we work with someone that does more of the sublingual drops, which work well.
Yeah.
And they take a little longer, but I've seen great results with both. And I do have to bring that up to parents because especially in Houston, parents are just kind of the attitude of like, yeah, but everyone has allergies. And
Mhm.
I'm like, yeah, but everyone's allergies are not affecting them like they're affecting your kid. Also,
Right.
if we don't address these allergies, we're not going to make progress.
Mhm.
And I feel like in any scenario clinically, you kind of
Mhm.
have to bring it back to whatever the parent's concern is.
Mhm.
And so maybe they don't care about the allergies, maybe they care about the ADHD or whatever. And then I have to say, well, if we don't fix the allergies, then these ADHD symptoms may still linger.
Mhm.
So go get the allergies checked out.
Right. Absolutely. Is there anything else that you want to chat about before we kind of wrap up for the day?
No,
Anything
I
more?
mean, I would just like one thing that I always, for the dental practitioners that are watching, I think it can be kind of overwhelming to dive into this field if you aren't there. But I think it's really important that everyone learns how to screen kids for this. And the screening process is really easy. I mean, I use the Ferris 6 all the time, which is, it's free. It's research backed, it's free, and it's a quick way to just like screen all your patients in the office. And once you get into the habit of it, like your team, like your assistants will probably be able to do it. But the reality is we are responsible for catching these kids. And the sad thing is because of our diet, because of our poor air quality, we are the majority of children in your chair need this type of treatment. And
Mhm.
so even if you're not there ready to treat yet, like screen them, partner with someone that you can refer to, and changing your mindset of expansion needs to happen 7, 8, 9. I start expansion as young as 12 to 18 months old. So it's possible, especially if you're a pediatric dentist. So if anyone is curious about like just how to screen, feel free to reach out. I'm happy to share some tools. It's a good place to start, and it's really our responsibility as dental practitioners.
Absolutely. Thank you for that. And where can people find you? How should they contact you? Social
Yeah.
media, website?
So yeah, social media, Instagram is probably one of the easiest. My practice names are West U Pediatric Dentistry and Tanglewood Pediatric Dentistry. And they're both in Houston, Texas. I also have a kind of teaching arm called Function First University. It's also on Instagram. But yeah, if you look up our practices, you can find our email on there or Instagram message us, and we'll be happy to reach out. You can find out information about the courses I teach, both on tongue ties and early expansion.
Awesome. Thank you so much for your time.
Thanks for having me.
Yeah, thank you for all you do. Your patients are just so incredibly lucky.
Thank you.